Okay, we're back for the last segment of the show, and that was a nice small break. Anyway, I want to remind the audience that that call-in number is 727-8750, and certainly if you're out there listening and you have any questions about COPD or what we've talked about or any other issue, please feel free to call in. We might be able to answer that question for you before we go off the air tonight. And again, getting back to the treatment, I was talking about albuterol, which is one of the things that everybody tends to be used. Again, COPD and asthma, there are some asthmatic conditions where and COPD can kind of run hand in hand, but they're really two different issues altogether. Asthma is an inflammatory disease, and it's very important to differentiate the two. And even though chronic obstructive pulmonary disease has acute exacerbations, which means that you have infections, bacterial or colds or things of that nature, it's not the same as asthma. And albuterol, which is a bronchodilator, a beta agonist, used in asthma can be deadly. And what happens in that condition in the asthmatic patient is that you haven't gotten at the cause of the disease. Cause of asthma is inflammation. Inflammation causes bronchospasm or narrowing of the airway. The result to someone watching someone could be the same thing. They could just be coughing and wheezing. But to the trained professional, there's a huge difference between the two, and they need to be treated totally differently. Asthmatics have to be on some corticosteroids or other medications that reduce the inflammation, and therefore then they reduce the wheezing. And we use albuterol in asthmatics to determine the severity of disease, and it's called the rules of two. And what that means is if you're an asthmatic and you're using your albuterol or your what they call a rescue inhaler more than 2 times in basically a week, or you're making more than 2 trips to the ER in a year, or you're going through more than 2 canisters in a month, then you have an asthmatic condition which has not been controlled. And sooner or later, your body is not going to be able to open up your lungs in response to albuterol. Remember, it's a rescue inhaler, and you will die from asthma. And this is how people do die from asthma. As opposed to COPD, that's a different story altogether. Their bronchospasm occurs from chronic mucus and chronic cellular debris and other stuff that's in their lungs that they can't get out, and that causes irritation, and then that causes congestion, and that causes wheezing. So in a lot of COPD, we do treat with corticosteroid because we're trying to reduce the inflammation in the lung based on all of the infection and the other things that take place. But that's not the same as asthma. So I don't know if that explained it to you, but just remember that if you have asthma, you're not to use your rescue inhaler. If you have COPD, pure COPD, it is permissible. And they do make a 12-hour bronchodilator. Very good for chronic obstructive pulmonary disease, very, very bad for asthma. If you're on one of these 12-hour bronchodilators and you have an asthmatic component to your COPD, you could be setting yourself up for a very severe downfall because when you go to your rescue inhaler, it will not work. And most people don't use their rescue inhalers correctly at all. They basically try to take that puffer and they try and hold it right there in their mouth and spray it, and they try and inhale it. Well, I don't know about you, but I can't really catch something that's coming out of that jet at 200 miles an hour and expect that I'm already having difficulty breathing, and I'm supposed to get all that down into my lungs, and I'm supposed to be able to time that correctly, and I'm supposed to be able to do that and get that in there. No, it doesn't happen that way. In fact, most people who use an inhaler incorrectly are getting most of that stuff on the back of their throat, and so they're feeling the jitteriness associated with the albuterol. And that's because it's gotten into your mucous membranes and it's stimulated your heart, and therefore your heart rate went up, and that's that caffeine-like effect that you've gotten from that albuterol inhaler. So again, it's very important for you to use a spacer. Now, I show it in my office is just taking a paper towel tube or even a rolling up a piece of paper, and you hold, you know, that spacer or your inhaler device at the end of the paper, and you spray it into there, and then 1 second later you're breathing it in. And this allows it to aerosolize in there and then basically taking it down into your lungs. And if you've used your rescue inhaler correctly, then you should not feel a thing. Your body shouldn't feel a jumpy. You shouldn't feel your heart rate increase. You should just within 15 to 20 minutes notice that your lung basically has opened up and you're actually able to breathe a little bit easier, and your respiratory rate has come back down. So that's basically using those rescue inhalers. Chronic obstructive pulmonary disease patients will use the nebulizer, which is also, they add another substance to that called ipratropium, or basically it's a drying agent, again, to dry up the mucus a little bit to prevent mucus plugging, and it also helps to reduce what they call a bronchospasm. So those two compounds are basically have been the mainstay of treatment for chronic obstructive pulmonary disease for years, obviously in addition to quitting smoking. And there have been refinements in those, and there have been different things, like I talked about the L-isomer, and then the 12-hour long-acting bronchodilators, and then the inhaled corticosteroids. Now, there's a few of them out on the market. The one that I like the best, or the one that seems to work the best, is these powdered forms like an Advair. Very expensive. It combines a combination of a long-acting bronchodilator with a corticosteroid. Powder, for some reason, tends to do a little bit better than aerosol. The people that made that particular product went into a great depth to understand the particle size that it takes to make that happen. And what I mean is, if you ever remember when you were in school or a young kid and you used to do spit wads, which are basically throwing a piece of straw paper in a straw and then trying to spit it out as far as you can. If you didn't get it right, you didn't get the right density, you didn't get it very thick, or you just didn't, you were trying to shoot it across the room, and sometimes it didn't make it. Well, particle size is very important in the lung tissue also, because when you inhale different particle sizes, they deposit in different areas of our lung. The smaller they are, the lighter they are, the further they might go, but actually the heavier they are, the further they might go. And this thing is the same thing that happens sometimes when you're actually shooting a bullet. The heavier bullets go the further, the lighter bullets tend to drop off a lot further. So they understand, the manufacturer does, which particle size deposits into the small airway. So, and I couldn't call it a controlled study, but I've had patients that have had both the inhaled cortisone products with the broncho things, and if they don't time it right, they don't get the right amount, they're not getting the medicine into the small airway, where this is where the disease process is going on. But these particulate sizes are just the right size and just the right diameter to end in the small airway. So they're much more efficient products, and they do much better. So if the doctor, if your insurance company, the evil insurance company has said, oh, well, that's not on our formulary any longer, we want you to take this product, and you've been on Advair, or you've been on one of these better products, and you notice that you're coughing more and you're wheezing more and you're becoming more short of breath, you need to talk to your provider about it, because they can fill out a prior authorization form called a PAR, and your compliance with this particular product is one of the reasons why your insurance company will have to afford or pay for the more expensive medication, because you're not going to take it any longer. So people don't realize that, no, you don't have to have a reaction to the medicine you're taking, and no, it doesn't have to be because it's just too expensive. It could just be because it's non-compliance, meaning if it's not working, then you're going to want to take something that works better. So I want to bring up one slide. We're going to end this show pretty quick, and I want to talk about one thing. We're going to talk about smoking, and I just want to, again, bring this up. Chantix, Zyban. Remember what I said earlier, that acupuncture, hypnosis, and patches all had about a 20% success rate. Chantix actually has about a 35% success rate. I know we talked about drug addiction, but cocaine and nicotine. Nicotine is almost as addictive as cocaine. The difference between nicotine addictions is that you get sick before you die, and with cocaine, you basically feel good all the way up until the time that you die. So anyway, these other drying agents, I want to talk a little bit about that. Again, Spiriva is the 12-hour one. If I had to do one or two agents, I would want to be on the Advair before I did the anticholinergics, and have your doctor recheck your pulmonary function test after they started treatment. It's an objective measurement on how you do with regards to each of those particular tests. So if he starts a treatment process on you, a longer acting agent, do it for a couple of weeks or 3 weeks or 4 weeks, and then have another pulmonary function test to see how you're going to do. Anyway, that was a lot of information tonight. It's a very complex subject, COPD, and I hope it sparks some interest in you to see your provider and get help with regards to that. And again, above all, quit smoking. This is Dr. Michael Reiner. Thank you for tuning in tonight. We'll see you here next Monday night. Thank you.